Module 12, Circulation, Shock and TXA. What shock is, how to see it before the cuff does, and when to stop treating it. Shock is delivery failing demand, not a blood pressure reading. The body compensates first: faster pulse, faster breathing, clamped down blood vessels to the skin. Compensation holds the pressure while perfusion is already failing, which is exactly why the pressure falls late. By the time the cuff agrees there is a problem, the casualty has been shocked for a while. The figure is illustrative, and the pattern is the lesson. Pulse climbing, pressure sliding, concerning when the pulse character weakens, the skin cools, the breathing quickens, the mentation dulls. The pattern prompts reassessment. It is not a diagnosis on its own, but it buys you the hour that the cuff would have cost. The table of different types of shock is a starting framework. Mixed shock is common, and hemorrhage is considered first in every trauma casualty until excluded. 6 physiologies, 6 different first moves: blood for hemorrhage, adrenaline for anaphylaxis, antibiotics and fluid for sepsis, the cause for obstruction, caution and a consult for the cardiogenic heart, fluid and a consult for the neurogenic. One generic response to all 6 treats a word instead of a casualty. These figures illustrate typical findings in shock: mentation falling, a fast thready pulse, cool, pale, sweaty skin, quick breathing. Any one alone is noise. Together they signal shock. The sequence: build the composite picture, name the likely physiology out loud, start the treatment that matches it, consult and arrange movement. Naming the cause is not academic. It is the step that stops the reflex of hanging a bag of crystalloid on every kind of shock. Volume cannot outrun an open vessel in the long run. Recheck every hemorrhage control before and during resuscitation. Where blood is authorized, blood is preferred, otherwise warmed crystalloid, 1 unit or bag at a time, to the coarse endpoint, radial pulse, improving mentation, systolic around 100, above 100 with a head injury. Controlled resuscitation is a balance, and both sides of it hurt. Too little, continuing hypoperfusion. Too much, popped clots, a cold wet casualty, an empty supply tomorrow, and diluted clotting factors if using crystalloids. The discipline may be boring, but it works. Give 1 bag, reassess against the endpoint, stop when you arrive at said endpoint. Then keep monitoring, as reaching the endpoint once is not a discharge. According to our med card, TXA should be given in massive bleeding. 2 grams, slow intravenous, intraosseous or intramuscular push for massive bleeding or traumatic brain injury. As early as possible and never after 3 hours from injury. Past that line it stops helping and may harm. Which is why the injury time is boxed at the top of every record. The TXA clock starts at wounding, not at your arrival. Once shock is treated to the endpoint, ongoing intake is a different problem with a different logic. Oral electrolyte when the casualty can swallow and the abdomen allows, and intake and output recorded as a pair. Shock care fails when 1 measurement or 1 treatment runs the show. A compensated casualty pronounced fine on an acceptable pressure, crystalloid poured at a septic or cardiogenic picture, and the resuscitation that never stops because nobody wrote down what the endpoint was. From this module. Shock is read from the composite and the trend, the pressure falls late. Name the physiology before choosing the treatment, and start what can be started while arranging the consult and the move. And treat to the applicable endpoint, then stop. Sources on screen. Module 13, Transfusion Forward, the gated module.